Okay, so this is the last portion. This is the last portion of Chapter 3. It's kind of late. It's a little bit, I get a little bit delirious in this recording booth. But this is part F for fantastic. And I'm going to talk about positive end expiratory pressure. Back to the VEN. Part A, increased lung volume. Part B, just decreased intrathoracic pressure, my mini Mueller. Part C, spontaneous ventilation, which is the summative effects of both decreased intrathoracic pressure and increased lung volume. What's that? Part D, just increased intrathoracic pressure and the mini Valsalva. Part E was the two of those combined. We just talked about increased lung volume and increased intrathoracic pressure. And that is your intermittent positive pressure breath or ventilation. And now let's get on to this last section and talk about the application of end expiratory pressure. So the application of end expiratory pressure imparts a steady state alteration in hemodynamics. And I think I talked about this in an earlier section. That is that when Fessler and Permut review this topic in one of their mini papers from the early 90s or so, or even the last 10 years, they differentiate the effects of transient versus steady state changes on the cardiovascular system. And the transient effects are basically the result of a breath, and they stress the cardiovascular system during the change in lung volume or change in intrathoracic pressure, and then they return to baseline after that stress reverses itself. Excuse me. And this is essentially like a breath, whether it's spontaneous or mechanical. And this has important implications mostly for Chapter 8 when we're talking about dynamic indices of cardiovascular monitoring. But they tend to be less important in terms of the patient's overall cardiac state. And that is more of the result of not a transient, but a what do they use? A phasic? No, phasic. I'm sorry, I'm losing my mind. It's PEEP is more of a steady state effect. Like IPPV, PEEP affects the cardiovascular system by both increasing intrathoracic pressure and lung volume, but again, it's a steady state effect, not a transient effect. By increasing the lung volume in proximity to the cardiac fossa, PEEP can decrease the effective compliance of the pericardium, which can augment diastolic ventricular interdependence. PEEP also has steady state effects on the venous return curve, and it was long held that PEEP decreased, and I actually still hear people say this in the intensive care unit, that PEEP or an inspiratory breath decrease venous return by impairing the gradient for return. And the key word here is gradient. Well, in actuality, interestingly enough, the gradient for venous return isn't really changed by PEEP and positive pressure ventilation. And you can understand why that is. You've already seen why that is. And that's because when you increase lung volume and you compress the venous capacitance beds, it actually augments systemic venous return. So even though you're increasing the back pressure to venous return, which would tend to decrease the gradient, I agree, you're also increasing the pressure head, which tends to augment venous return. So in actuality, these maneuvers do not affect the gradient for venous return really much at all. And I think that this was sort of first touched upon or suggested by Scharf and colleagues maybe in the early 80s. And then it was really experimentally confirmed by Fessler et al. In the early 90s as to how PEEP truly affects the venous return curve. And what PEEP does is it has twofold effects. And the first is that it tends to increase the resistance to venous return to a minor extent. But more importantly, it can significantly diminish maximal venous return. And diminishing maximal venous return is basically like you can think of it like making collapse of the great vessels as they traverse into the thorax, it makes collapse of those vessels much more likely. It decreases the threshold for collapse of those vessels. So the increase in pleural pressure is transmitted to the right heart and increases the IVC pressure, but it also increases abdominal pressure. So this is kind of my depiction of increasing the pressure in the right heart, and it creates this gradient down the IVC, but it's simultaneously increasing abdominal pressure as the diaphragm descends and the volume of the abdomen is diminished. So there's this blood flow gradient that we've talked about previously, but because of the pressurization of the abdomen that occurs with the descent of the diaphragm, it actually facilitates this Starling resistor or vascular waterfall effect, where the pressure within the abdomen can compress the IVC, and therefore that creates this plateauing or maximal venous return. So you can imagine this become very prominent in a patient who's on PEEP, but also generating his or her own negative inspiratory pressure, because they would essentially pressurize the abdomen, but at the same time they begin to lower their right atrial pressure and therefore really diminish IVC pressure out of proportion to abdominal pressure, so you'll get collapse much more readily. So any drop in right atrial pressure, as I mentioned, from a spontaneous breath will cause the IVC pressure to fall below the pressurized abdominal cavity, and there will be collapse. So this is truly the effect of PEEP on venous return. So if this is your normal euvolemic patient here, and then you PEEP them, you tend to augment this. The mean systemic pressure is probably actually shifted out to a greater extent here. What actually happens is, and I apologize, I didn't animate it terribly well here, but this pressure here at which maximal venous return occurs, which really typically occurs a few millimeters of mercury below atmospheric pressure. In all my cartoons, I do it at atmospheric pressure just to make the cartoons a little bit more aesthetically pleasing. The pressure at which maximal venous return is sometimes called P-crit, or critical pressure. And when you give somebody PEEP, the amount of pressure, the amount of increase in P-crit, so in this situation it would be from atmospheric pressure to, say, here, I don't know what this is, say 5 millimeters of mercury. So P-crit has increased, say 5. It tends to increase your mean systemic pressure by the same amount. So in actuality, the mean systemic pressure should also increase by roughly 5. So in actuality, the gradient, as you can see, doesn't really decrease at all. But the resistance of venous return increases, and the maximal venous return is diminished, and it occurs at a higher pressure. That's what I talked about. So let's talk about PEEP in the right ventricle. So the increase in pleural pressure from the PEEP is transmitted to the right atrium, but the gradient for venous return is really not diminished at all. At high levels of PEEP, up to 15 centimeters of water or so in the healthy lung, there's evidence for the induction. Above 15 centimeters, there's evidence for induction of diastolic incompetence and elevated afterload for the right ventricle. The afterload effect of PEEP tends to predominate when the transpulmonary pressure is very high, / when the lung volume is very high. So let's go through this graph again. Repetition is good. Again, this is your airway pressure or pleural pressure, depending on which graph we're looking at. So this is the elastance curve of the lung and chest wall together. So this graphs out the airway pressure that you would measure at the proximal trachea on the ventilator. If you were to apply PEEP, the airway pressure, as you imagine, would go up to a small degree depending upon the compliance of the lung and chest wall. But the increase in pleural pressure, again, will follow the chest wall compliance curve, and that is the PEEP will increase the volume of the lung, and then the lung will press out against the chest wall, and the pleural pressure will rise along the chest wall compliance curve. And that's the effect of PEEP. So now let's juxtapose the Guyton analysis. So we now have blood flow on the y-axis, and now we have on the x-axis, this is right atrial pressure. This is your CVP that you're measuring here. The transmural pressure is the intrathoracic pressure, or the pressure across the right atrial or the right ventricular wall is the transmural pressure, which is the pressure within the cavity less the pressure outside the cavity. And because the pressure outside of the cavity is slightly subatmospheric, the distending pressure tends to be somewhat greater than is measured by a fluid-filled catheter that is referenced to atmospheric pressure, which is what we do when we measure a CVP. Okay, so applying PEEP, well, you're going to increase your intrathoracic pressure to the same extent that that you're going to shift your right ventricular cardiac function curve rightwards to the same extent that you've increased intrathoracic pressure. So from FRC, which is about here, the PEEP raised your intrathoracic or pleural pressure to about here, and that corresponds to this rightward shift in your cardiac function curve. So it tends to be a small diminished transmural distending pressure. So the PEEP will tend to diminish the volume of the right heart, increase your pleural pressure, increase your CVP, and diminish your right ventricular forward flow to a certain extent. And this becomes your new baseline. So this is why this is a steady state effect. This isn't a transient effect like we've been looking at where the inspiration is completely reversed on expiration. This is a steady state reduction in your cardiac output and a steady state reduction in the transmural pressure of your right heart. So the extent to which PEEP increases the transpulmonary pressure, remember this is the extent to which it increases the lung volume, determines the increase in right ventricular afterload. And this tends to be very minimal in healthy lungs with PEEP below less than 15 centimeters of water. So there may be a very small downward shift of your right ventricular cardiac function curve, but again, very minimal. But as we mentioned, PEEP changes the venous return curve. So in this situation, you've decreased your maximal venous return, and now this patient's actually operating on the speed limit of their venous return, or this is as high as they can augment their cardiac output. There's no way you can get this any higher unless you somehow increase your mean systemic filling pressure by giving volume or giving an adrenergic agent. So this patient now effectively have decreased their cardiac output. Why? Because if they were previously on this ghost venous return curve, if they were to inspire by dropping their intrathoracic pressure, they'd be able to augment their cardiac output along this venous return curve here and actually get it all the way up to here. But now, because of collapse of the great veins, this is the highest they can get their cardiac output. So as they inspire, they're not going to increase their cardiac output anymore. That is, if they were to generate a spontaneous breath on their own. If this patient were completely sedated and paralyzed, well then this is their new baseline, and they'd only be able to shift the cardiac function curve rightwards and then back again, and then rightwards and then back again. So this essentially is still the maximal venous return. This is still the maximal cardiac output, and with a positive pressure breath, and if the patient were paralyzed and sedated, they would only actually decrease cardiac output. So this is why the application of PEEP results in a steady state decline in your cardiac output. So what about the LV? Again, conflicting effects on the LV. The application of PEEP tends to shrink the LV preload and volume as a function of the decrease in right ventricular output. To the extent that the PEEP increases lung volume, there may be compression of the LV lateral wall, which can compress the septal lateral dimension of the LV, but again, this tends to be minimal in health. And many studies of PEEP on the LV have demonstrated this non-uniformity of forces upon the ventricles in terms of shape change of the LV. Positive pressure can also decrease the LV afterload and therefore increase stroke volume by decreasing the end-systolic volume, but this effect is really limited by the more pronounced decrement in end-diastolic volume in the healthy heart. Again, reiterate, the left atrium and pulmonary veins are exposed to the same increase in intrathoracic pressure, so they both shift rightwards in unison relative to atmosphere with the application of PEEP. And I talk about this in Chapter 7 on the wedge pressure. If you want to account for this change using the index of transmission, you can, and you can see my cartoons illustrating that physiology in Chapter 7. But I'm not depicting this shift just for simplicity. But PEEP is a steady state effect, so it does tend to reduce blood flow to the left heart, which is secondary to decreased flow from the right heart, and therefore PEEP can shift the pulmonary venous return curve leftwards relative to the left heart function curve, in effect like hypovolemia. So again, moving through this PEEP application, it's going to increase your airway pressure to this extent. From FRC, the application of PEEP will increase your pleural pressure along the chest wall compliance curve, as we've already talked about. We'll superimpose the Guyton analysis in the right heart. Again, the increase in pleural pressure tends to shrink right ventricular cavity pressure, diminish right ventricular outflow. It also changes systemic venous return, as we saw. And this is a new baseline. There's a new baseline diminished cardiac output. But how does this, affect the LV? Well, the application of PEEP can cause diastolic impairment of the LV by heart-lung interaction. For basically what I talked about before, this, as the lung increases in volume, it can impinge the lateral free wall of the LV, which tends to be minimal in health. Or if PEEP is excessive, in addition, if it to the extent that it afterloads the RV, it can cause RV dilation, which can impair LV compliance. And again, these are much more prominent effects in disease states that we will talk about in Chapter 4. But also in pathological states, most notably profound systolic heart failure, PEEP can also improve left ventricular afterload and shift the left ventricular cardiac function curve up and to the right. So down, up, again, these effects are minimal in health. And PEEP, as mentioned before, because of the steady state reduction from RV, right ventricular output, PEEP tends to shift the pulmonary venous return curve leftwards relative to the left ventricular cardiac function curve, which reflects this decrease in the maximal venous return from the periphery to the right heart is then reflected to the left heart by diminished pulmonary venous return to the left. So that was a whirlwind tour of heart-lung interactions during health by using the juxtaposition of the Campbell and the Guyton analyses. I hope that it wasn't too busy or too overwhelming, but what I do want to illustrate is that there's a multitude of effects that occur with regards to the physiology of the cardiovascular system, and it's primarily a function of changes in intrathoracic pressure and lung volume, and that it's mediated by both changes in systemic venous return, cardiac function, pulmonary venous return, and that understanding all the different effects that can occur will help you appreciate when certain pulmonary and cardiovascular physiologies go awry and then begin to interact, as we'll talk about in Chapter 4, how a lot of these effects can become exaggerated, and you may have a predominant pathophysiology in one aspect of heart-lung interaction that can be reversed through various therapeutic maneuvers. So thank you very much for tuning into my Chapter 3. I hope you stick with it. Hope that you're in a happy place, and thanks for stopping by.